So good morning, everyone. And first of all, I would like to thank the organizers for including this talk in this session and giving me also the possibility to attend the previous talks, which were kind of quite impressive and informative. So I'm working as medical director for Beckman Coulter Medical and Scientific Affairs, and Beckman Coulter is the company which produces equipment for the laboratories. And on one of our instruments, recently we have FDA and CIVD clearance for the new sepsis biomarker, which is called Monocyte Distribution Width. Okay. This is educational presentation because some slides will contain off-label information, so we don't promote any off-label use of our products. First of all, we will go very quickly through the introduction into sepsis and biomarkers because it has been already covered by the previous speakers. We will review principles of the measurement of MDW so that you know what is this biomarker about. And then we will review the published data on the performance in the emergency department and also in intensive care unit. So, as you know, for many years, sepsis 2 criteria were in place, and you know this story probably much better than I. So I move to the slide with sepsis 3 because currently sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to the infection. And as it has been already described, there are so-called SOFA criteria, which are used for sepsis definition and increased of 2 or more points in SOFA criteria. This is indication of sepsis. QSOFA have been in place for quite some years, and sometimes they were used as the diagnostic criteria, but recent recommendations discouraged from using QSOFA for the diagnostic because they are more prognostic criteria. And you know very well that there is definition of septic shock, which is sepsis when the patient is refractory to vasopressor treatment. And the difficulty of the sepsis is not infection by itself, but this is inability of the immune system to fight with the infection efficiently, because normally you have pro-inflammatory response and at the same time anti-inflammatory response in the patient. When the severe inflammation is not needed, it should be stopped if the body is working as expected. But if there is immune dysregulation, can be 2 possible complications. First, when pro-inflammation is increasing and does not go down, then patient may die because of cytokine storm. There were a lot of deaths due to cytokine storm in the COVID time, as you know very well. On the opposite side, if the immune system is not able to respond efficiently to the infection, patient may go into the sepsis-induced immunosuppression. And this is another big portion of the patients who are dying from sepsis because they are dying from sepsis-induced immunosuppression. And moving to the sepsis biomarkers, there are many of them. Back in 2010, there was very nice review published by the guru in sepsis, who is Jean-Louis Vincent. They published paper about available biomarkers, and they have reviewed more than 3,000 papers discussing almost 180 biomarkers. Many of them were at different stage of the research or sometimes even clinical implementation, but majority of the labs and clinicians are using, generally speaking, 2 of them, C-reactive protein and procalcitonin. Few years later, they repeated the same review. They published another paper, and as you can see, there were more than 5,000 new references. There were 80 new biomarkers compared to the previous review. And again, majority of biomarkers have been evaluated in very limited number of studies. Very few of them found the way to the clinical practice, which give us the understanding that sepsis is a very difficult field for the diagnostic because this is not homogeneous disease. Sepsis may present very differently. One situation is like story described this morning, and very different can be 85 years old patient on the immunosuppressive treatment presenting to the ED department with very vague complaints without clear clinical presentation. So every time the clinician is expected to combine together all the details about patient history, all the information available from the laboratory tests, from other investigation, and take the decision for each patient individually. There is no gold standard how to, diagnose easily sepsis in all the patients. So, and talking about biomarkers, because sepsis is defined as organ failure. So all those biomarkers which may indicate to some extent organ failure can be used in sepsis diagnosis. And it was, as it was perfectly mentioned in the previous talk, in the future, most probably AI to some extent may help to derive, score or combined biomarker based on different elements. But up to now, there is no gold sepsis biomarker. There is no biomarker with the perfect performance, with very high sensitivity and specificity. You can see from this table that in most of the papers, the biomarkers which was studied are again PCT and C-reactive protein, then there is interleukin-6 and some other biomarkers in very low number of the studies. And area under the curve for most of them is between 0.7, 0.81. There is one with very high area under the curve, CD64. This is really good biomarker, but it requires flow cytometry equipment, and this is not something which is easily available in every hospital and in every lab for the patient assessment, especially in the emergency department. Ideally, we would like to have biomarker with very high sensitivity and very high specificity, but this and cheap and available for everyone. It does not exist, hopefully, yet, but maybe it will never exist. And this is why, as I said, all the biomarkers available up to now should be combined together. Now let's go into the monocyte distribution width. And from the very beginning, I would say that as all other biomarkers, this is not ideal test for sepsis, but it has some very definitive advantages, and you will see which of them. How this biomarker is obtained. It comes from the hematology instrument, hematology analyzer which generate CBC-diff result. And as part of the analysis, this instrument is measuring the size of the cell, volume of the cell. This is done on the DXH900 analyzer from Beckman Coulter. And when the instrument is measuring the volume of the cell, it's able to build the histogram of the distribution of the cellular volumes. And from this histogram, we can get standard deviation of the monocyte volume. This is measurement of the monocyte anisocytosis, variability of the monocyte size. We know up to now that in normal monocytes, this variation of the size somewhere in the normal range, but when patient has infection, then severe infection, and may have sepsis, the monocytes would change their function and they would change their morphology. And as the result of this morphological change, standard deviation of monocyte volume will increase in the patients with severe infection and sepsis. This is what you can see on the right part of the slides. You can see cells with abnormal morphology, and you can see increased standard deviation of the monocyte volume, or MDW. And you can ask me why Beckman decided to release biomarker based on the monocytes. The short answer, I can talk like another story about monocyte biology and their role in sepsis, but the short answer is that monocytes are involved in two key events in sepsis pathogenesis, what I mentioned earlier. The one of them is pro-inflammatory state, because monocytes are key cells which initiate production of pro-inflammatory cytokines, and if it's not regulated properly, this may result in the cytokine storm, overwhelming inflammation, and organ failure, and sometimes patient death. But on the other hand, monocytes are key players in sepsis-induced immunosuppression. And because they are involved in these two opposite processes in the patient with sepsis, we can see increased, in the literature you can find information about increased functional heterogeneity of the monocytes in sepsis, which translates into morphological variability and which can be detected with the increased monocyte distribution width. In the left graph, you can see two-dimensional plot of the analysis of the cells. In the green color, you can see population of the monocytes. On the vertical axis, this is the measurement of the volume. And when we see extended monocyte population from top to down, this is the indication of the increased MDW. This is the example of the screen from the analyzer. Unfortunately, the screen is small, so you cannot see where MDW is. It's at the bottom of the differential results. In this patient with sepsis, MDW is 28, and you can see here extended green population of the monocytes with the increased MDW. I put on this slide the intended use statement from instruction for use for our instruments. And from here, you can see how this biomarker is supposed to be used. We have clearance for the adult patients presenting to the emergency department on whom a white blood cell differential test has been ordered. So it doesn't have yet the IVD and FDA clearance for children, only for adult patients. Second important point is depending on the type of the EDTA tubes, which are used for the CBC-diff analysis, there are two different cutoffs for the MDW. For K2 EDTA tubes, cutoff is 20, above 20, high probability of sepsis. If MDW below 20, low probability of sepsis. And for K3 EDTA tubes, cutoff is 21.5. And as I said before, and what we put in our IFU, MDW is not supposed to be used as single biomarker for sepsis. It should be used in association with other clinical information and diagnostic testing available for the patient. You can ask me how early we can observe the changes in the monocytes morphology and MDW. You can understand that it's quite difficult to perform study in patient, taking blood from the patient having sepsis in short time. We haven't done it yet. But what was done by Professor Ferdinando Manello from University of Urbino, they analyzed blood cells in the culture, and they treated blood cells with lipopolysaccharides, with histones, or just with histones. Those are proteins which are released in case of infection. And as you can see on this graph, with the blue triangles, you can see MDW in the sample which was not treated, and red and green marks are the treatment with histones or with lipopolysaccharides with histones. And you can see that in as short as 30 minutes, in those in vitro experiments, we can see increase in MDW after this treatment. So this gives us good evidence that monocytes, they really react quickly. We may not see it yet under the microscope for multiple reasons, but the instrument which is measuring precisely the volume of the cells and anisocytosis of those cells can detect those changes very early. Now let's go through the published performance on MDW. We did clinical trial for the FDA submission in United States. It has been done in 3 big university hospitals and included more than 2,000 patients. Data were analyzed using both sepsis definitions, sepsis 2 and sepsis 3. Here you can see some results. Left plots show you the dynamic of MDW in different groups of patients. Left graph with the A, this is changes of MDW in the groups according to sepsis 2 definition, and B, this is the plot with the changes of MDW according to sepsis 3 definition. So for sepsis 2, there are control, SIRS, infection, and sepsis, and for sepsis 3, there are control, infection, and sepsis, because there is no SIRS with sepsis 3. As you can see in both situations, MDW is nicely increasing with the worsening of the patient condition. In terms of area under the curve, MDW by itself produced area under the curve 0.79. This is not fantastic area under the curve of 99 or 95, but please keep in mind that this is the biomarker which is available from CBC-diff analysis. You don't need to get extra blood from the patient. You don't need to order this biomarker. You don't need to suspect sepsis from patient. You just need to check this result when it comes back with CBC-diff analysis and see where MDW is, and then build it into your decision for this individual patient. Also, in this clinical trial, the investigators tried to combine together MDW and white blood cell count. White blood cell count is used for years as indicator of potential infection in the patients, and when MDW and white blood cell count were combined together, you can see area under the curve went up to 0.85. At cutoff of 20, MDW demonstrated sensitivity of 74 and specificity of 72%. The same data set has been analyzed by similar team, and they checked how MDW can be combined with the existing sepsis criteria like SIRS and QSOFA. This has been done before QSOFA were recommended not to be used for diagnosis. And practically speaking, they've demonstrated that MDW can be used as additional SIRS criteria. Instead of 4, you may have 5, or additional 4th QSOFA criteria. And this really improves the management of the patients. After the study in US, we have done study in Europe. In Europe, study was done in 2 big university hospitals, one in France, in Paris, PT-Salpêtrière Hospital, with Professor Pierre Hausvater as principal investigator, and second hospital was hospital in Badalona in Spain. Together, they collected more than 1,500 patients presented to the ED in those 2 big hospitals. Results you can see on this slide, and as you can see, MDW by itself in the upper line demonstrated again very convincing area under the curve for both sepsis 2 and sepsis 3 above 0.8. Combination of MDW and white blood cell improved performance in both cases. This improvement was more visible in case of sepsis 2. What is interesting that combination of MDW with C-reactive protein or procalcitonin did not significantly improve their performance compared to combination of MDW and white blood cell. And once again, the advantage of MDW is its routine availability. Since then, we have currently almost 100 publications discussing MDW in different settings. There were a lot of papers on MDW in COVID. We have publications on MDW in ICU, and now it's time when there are already several meta-analyses published on the MDW performance. I'm showing here 2 of them, one from Taiwan and another from United States. Both of them came up with the conclusion that this biomarker has quite reasonable sensitivity and specificity and area under the curve, and they highlighted that the first paper highlighted that due to high sensitivity, MDW could serve as screening tool to exclude the possibility of sepsis in suspected patients. It has high negative predictive value, and if it's normal, this is good indication that probability of severe infection and sepsis in this patient is quite low. Another paper highlighted that the advantage of MDW is that incorporation of this biomarker may help identify severe infection in sepsis in patient when it's not suspected. As I said, patient may present with the very vague symptoms, not doing well, but not clear why, and in this case, MDW can be extremely helpful. And also, I would like to show you a little bit more details with all the experience what we have from clinical usage of MDW, how we believe this biomarker can be helpful for the clinicians. We developed this interpretation guidance for K2, and next slide will show the same for K3. Idea is the same, just numbers are slightly different. So generally speaking, if MDW is below cutoff, the probability of sepsis is quite low because negative likelihood ratio is quite low. If MDW goes up, and when it's in the range for K2 tubes between 20 and let's say 24, this is moderate risk of sepsis. This is not dramatically high MDW. This should be taken into account, but probably the doctors may have some time, to take decision and to have more investigation for the patients. If MDW is very high, if it's above 24 up to 26, this is high risk of sepsis, And if it's even above 26, this is very high risk of sepsis. This is really a red flag for the clinicians when they need to act quickly and consider seriously possibility of sepsis in this patient. And this is the same results from K3 tubes, and you can see very similar picture, just all the cutoffs are slightly higher because we have different cutoff for K2 and K3. And now I would like to present a few slides on the MDW in ICU. And I believe you know better than me why sepsis detection in ICU is important, because first of all, some patients are arriving already with sepsis in ICU. Some of the patients develop sepsis during the ICU stay. And on the top of it, in many ICU patients, the signs which are used as trigger for the infection may not be due to the infection, but due to the illness which patient has. And I'm showing you just result from one publication, which was published by Professor Plebani from Italy a few years ago. They collected 500 patients from ICU, and they used sepsis 3 and K3 EDTA tubes. And as you can see here, again, no sepsis, septic shock in the left graph. You can see nice increase in MDW values. The higher MDW, the worse patient condition. Area under the curve gave the number 0.785. Cutoff for ICU patient was different from the recommended cutoff for ED, because patients in ICU are different from the patients in the emergency department, and cutoff for ICU published in this paper was 24.6. They compared performance of MDW with PCT and CRP. Yeah, and I forgot to mention when we were talking about ED, if you compare the results for area under the curve for MDW, C-reactive protein, and procalcitonin, they all have similar area under the curve with very overlapping confidence intervals. So performance is very similar. Here you can see again that MDW gives area under the curve 0.785, PCT 759, and CRP 667. What is interesting for ICU patient, white blood cell count did not really work well, 0.57. They also checked the MDW in different types of the infection. You can't see these small letters. Fungal, gram-negative, gram-positive, no pathogen identification, SARS-CoV-2, and viruses. So as you can see, MDW is pathogen agnostic. It's elevated in all types of the infection, fungal, viral, and bacterial. They also checked the value of MDW for patient follow-up. On the left part, you can see survivors, and on the right part, non-survivors with sepsis. First and last MDW measurement, you can see that for survivors, MDW went down when patients were treated. MDW was decreasing if treatment was working. When the patient unfortunately died, MDW stayed more or less at the same level through the course of the treatment. And before I go to the concluding remarks, I would mention that recently there was publication about clinical utility of MDW, which was done also by Professor Hausvater. They checked the time to antibiotics from the arrival to the ED and from the sepsis recognition between two periods. One period, their normal practice without MDW, and second period, when they put instrument and clinicians who used MDW, they were told if MDW is above cutoff, they need to consider sepsis in the patient triage. What they have demonstrated, there was decrease in the time to antibiotic from ED arrival. This difference did not reach statistical significance, but p-value was 0.06. So this is practically close to the cutoff of 0.05 to be considered as statistically significant. The time to antibiotic from the sepsis recognition was statistically significantly lower by 1.5 hours. And also in the second period, they observed less patients transferred to the ICU. And as concluding remarks, I would say that MDW novel sepsis biomarker intended for use with adult patients presenting to the emergency department on whom white cell differential test has been ordered. MDW performance for sepsis detection in the emergency department has been confirmed in multiple publications in various geographies and on various patient populations with consistent results. And we are quite sure for now that this is really perfect screening tool available from CBC-DIF with high sensitivity. This may be not perfectly specific, but high sensitivity will help you not to miss the patients with sepsis. And from the published literature, we can say that MDW could represent a biomarker of sepsis in patients hospitalized in the infection care units. That was my last slide, and thank you very much for your attention.